and sleep. Neck pain. There are 3 zones of neck pain that we as surgeons or spine doctors classify. So when you say I have a pain in the neck, we don't just say, oh, where? We say, where exactly is your pain? Is it pain in the neck or the back of your skull extending up to the top of your skull? Is it pain in the shoulder trapezial area here? Or is it pain in your arm, shoulder, radiating down to your elbow? Those have distinct origins or distinct causes of pain, and you can of course have a combination of those, but where those pains are and how you describe them to us are very important because it leads us to figure out where your pain generator is, what's causing your pain. Now, the vast majority of people who come in with neck pain is a soft tissue sprain or strain. Basically, your neck muscles, of which there is a rich network of neck muscles, work about 16 hours a day, holding up your 12 pounds of skull and head. And if you just did that and held up 16 pounds, you'd be pretty tired too. They can be overstressed and cause pain just like any other muscle or joint group. And the vast majority, 90%, heal within 4 weeks. So I see lots of patients coming in saying, I have this neck pain, what do I do? I just kind of give them some stuff to do to distract them for 4 weeks, and then 90% of the time I'll never see them again. And then they think I'm great. Another common complaint that we see is whiplash. It's a sudden change in the position of the neck. This is typically what you see when you're rear-ended in a car accident. However, it can be a very severe shock or strain to the neck, usually caused by, like here said, motor vehicle accident or a fall. And it's the muscle, tendon, ligaments are stressed beyond the tolerances. Once you have this kind of problem, where it's a severe injury, it's a very variable recovery rate and time and rate, and also keeps lots of chiropractors and lots of personal injury attorneys in business. And that's the problem is that once your pain after this extends more than 1 month, you're in this whiplash category, and you can easily extend it up to 2 years, and we're not sure why. And they've done experiments where they've tried to correlate the amount of injury energy to how long you have this problem, and it's very, very difficult to coordinate. And this can be without any radiographic evidence of injury. X-rays are negative, MRIs are negative, everything is negative, and you still have pain. And it's it can be a difficult problem to solve. Still, the vast majority do resolve without having to have surgery. However, if your injury is not just confined to your muscle, tendon, ligament complex, the nice thing about muscle, tendon, ligaments is the vast majority of them heal on their own, it can injure other more permanent structures, and then you're headed towards reconstructive surgery. So treatment for soft tissue injury, how do we start your treatment? Generally, we start with non-steroidal anti-inflammatory medications, which are basically ibuprofen and its prescription alternatives. A soft neck collar, you've seen the foam collars, and that's generally essentially the same thing as a brace. Just as if you twisted your ankle, you would go into an ankle brace. You've kind of twisted your neck, and you go into a neck collar. However, like with all spine braces, you don't want to wear them for an extended period of time. You don't want to wear them for months and months because they can decondition or weaken your neck. And then once your neck muscles are weakened beyond a certain point, then you have to start building them back up, and it can be very difficult to do that. Physical therapy / chiropractic treatment. I'm always asked what's better, physical therapy or chiropractic. And every human is different. So some people like therapy, some people like chiropractic. Chiropractic has good and bad practitioners, just like physical therapy has good and bad practitioners. So just because you have a bad experience with one chiropractor or one therapist doesn't mean that all therapy and all chiropractic is bad for you. Another one that I commonly use for people who either A, don't have insurance and cannot attend physical therapy or chiropractic sessions, or B, who have a kind of a nagging problem that's not quite to the level where they want to spend the time and effort going to therapy, but they still need some treatment, is cervical traction. And that's a setup kind of like this. And I tell people, yeah, just go to Amazon, pick the one that has the best ratings on Amazon, and it'll cost you about $30, and when you get it, you're going to feel like you got ripped off. Because it's really simple, it's really cheap. This is usually connected to a big plastic bag you fill with water. And I tell patients 15, 20 pounds, 15 to 20 minutes, 2 or 3 times a day. And for mild, moderate neck problems, it actually does a lot of things because essentially it takes all the weight off of your neck muscles. Your neck muscles don't have to do anything. It's almost like being weightless. And it gives them just a chance to rest and heal and recover. And then alternative treatments. This is something I've talked about before where you will get, for example, in the pages of the LA Times, how this laser spine therapy or this kind of therapy and this kind of therapy is going to be the answer for you. And they claim a 90% success rate. Well, if I have a 90% success rate by just telling you to wait 4 weeks, you know, yes, those things do have a 90% success rate, and so do I by telling you to do nothing and just wait. So you have to be careful with how alternative treatments sell themselves because in the vast majority of cases, they're going after your dollar because the insurance companies and Medicare won't give them their dollar. Believe me, insurance companies and Medicare have much, much more money than you guys have. So they would much rather have Medicare and insurance companies pay them than you personally. So if they're going out to you personally and saying don't go to insurance, it's because they already tried to go to insurance and insurance wouldn't pay for it. All right, so if you have persistent, severe neck / arm pain, any combination of the above, then I need to start looking at what is your pain generator? Where is your pain coming from beyond the muscle, tendon, ligament complex? And then now you're talking about permanent, irreversible injury to structures inside your neck. Oh, and so what I'm looking for is, this is looking at the cervical spine from the side. This is the front side, that's the back side. This orange stuff is bones. In between here is, actually this is a ligament that's torn between the two. This is a nerve that comes out through the bones. And then the disc is like the shock absorber cushion in the front of the spine. And then so this is one of the joints of the spine, in the front of your spine. Then there's another joint here in the back of your spine. And then the spinal cord kind of goes through it. So basically, I need to make sure or check all of those structures. The ligaments in between the bones. I need to make sure you don't have a fracture, so I'm checking your bones. I need to see if any nerve compression is going on. I need to see if you have an injury to the joint in the back, which is called a facet joint. I need to see if you have an injury to the front, which is called a disc. So let's start with nerve pain. Pain pushing on a nerve, and it's just like if you smack your funny bone, you have pain radiating down your arm into your fingers. So you feel the pain here, but the problem is here. In the case of nerve pain, you feel the pain down your arm, but the problem is in your neck. So this is a cross-section of the spine, and this here is basically as if I was standing above you looking down your spinal cord. This is your spinal cord, and it has nerves that branch off from the spinal cord through holes in the bone. And you can see here, this nerve is nice and happy as it exits through the spine. You can see here that the disc is pushing out here and is compressing the nerve that goes out and down your arm. And that would cause pain, numbness, tingling down your arm, and weakness. You can have disc, and then people always talk about where is the disc herniation? Is it a lateral? Is it a central? That's more my problem, but this is what a lateral disc herniation is, just affecting one nerve. But you can see that if this disc herniation was kind of more like this, it could be affecting both nerves. And it can also be affecting the nerve that goes down into your legs. And so these are all different problems that we have to deal with. The other issue, or the other question I'm always asked is, number one, oh, it's a 4 millimeter disc herniation. It's a 7 millimeter disc herniation. You know, the patients come in all concerned about the size of the disc herniation. And the size of the disc herniation, how many millimeters, is not the most important problem. When someone tells me how I have a 7 millimeter disc herniation, say, I need to see the images. Because people come in different sizes. Spinal cords come in different sizes. And spinal cord size does not always correlate to the size of the person. There are probably small women in here who have bigger spinal cords than some, of the larger men. It doesn't perfectly correlate. So the millimeters of disc herniation or the millimeters of protrusion really need to be assessed in comparison to the volume or the size of the spinal canal. So if you have a very small canal, a 2 millimeter disc herniation may cause you more problems than someone who has a large spinal canal and has a 6 millimeter disc herniation. So everyone gets caught up in the millimeters. It's not the millimeters that matters. It's the relative compression or the relative size of your canal to how much disc is actually in there. So nerve pain is, there's two kinds of nerve problems, radiculopathy and myelopathy. Basically, radiculopathy is where you're just compressing one nerve, so that's just shooting pain down to the arm. That's the most common problem. However, as people get older, as people age and their spine changes, then they get into, they can have more commonly a problem called myelopathy, which is where the entire spinal cord is being compressed. And what that does is, whereas radiculopathy, which is pain going down just the arm, is usually extremely painful, myelopathy actually can be painless. And many patients come in to see me just having balance problems. They're having difficulty walking, they're staggering, and no one can figure out why. Their neck's a little stiff, but sometimes not painful at all. And unfortunately, when that happens, it usually takes a long time by the time the patients have seen me. They may or may not have pain in the arm. They may or may not have pain. They usually have difficulty walking, incoordination, leg weakness, very, very brisk reflexes, spastic legs. They're walking as if they're, drunken sailors, that kind of thing. And there's some specific tests that we do, but really the best test to detect this, I found, is actually just having people go heel-toe along a line, just like they do in the sobriety tests. If you can walk heel-toe in a straight line without falling over, your spinal cord is okay. Pain generator. So location of your pain, where your pain is, leads us to look at certain areas more closely. If, for example, your pain is in your left arm, then I'm not going to care so much that you have a small disc herniation on your right side. The important thing to remember is just because you have a problem on your MRI does not mean that that is the cause of your pain. When they do volunteers who have no complaints in the spine, it's almost a ratio of your age to the percentage. So 50% of people, more or less, at age 50 with no problems in their spine will have abnormalities on their MRI. So just because you have a problem on your MRI does not mean that it is the cause of your pain. You have to make sure that that problem and the patient's complaints all match up. So basically, when you report that the pain is in the neck or in the back of your skull, radiating up to your head, what we call occipital headaches or headaches in the back of your head, sometimes to the side and the top of your head, that leads me to think that you have a disc problem. The disc, the cushion between your bones is wearing out, and that's what's called axial neck pain. Pain in the shoulder, in that trapezial area that we discussed about, leads me to think that it could be disc and it could be nerve. And just because it means that both are possible as the sources of your pain. However, if you have your pure pain in your arm, going all the way down to your fingers with numbness and tingling, then it's probably nerve pain. Something is squeezing the nerve. And then, of course, if you have more than one type of pain, you may have more than one type of cause. So a herniated cervical disc, I hope you guys can see this. This is looking at you cross-section. So this is the front of the spine, this is the back of the spine. This is a spinal cord, and you can see what happens to the disc here. It's squeezed out like a jelly donut. Unfortunately, when God designed us, he made the weakest part of the disc in the back part of the spine. I'm not sure why he did that, but that's what he did. Keeps me employed. And so the disc is just like a jelly donut. The little hole where the jelly goes in, the weakest part is pointed backwards at the nerve. So you can see the jelly has popped out and is crushing the nerve. This is the same thing that happens in the lower spine when people slip a disc, herniated disc, protruded disc, the same thing. You can kind of see the MRI. You see this patient is in big trouble. This spinal canal, although capacious, this patient has more than 50% compression of their spinal canal. And so that's a real problem. And then cervical degenerative disease, basically the, sorry, this thing got shrunk. Basically the shock absorbers of the spine are basically are bad, and it's just like as if you're driving down pretty much any California road with bad shock absorbers. Your bones are grinding against each other, and that's what can cause neck pain. So the treatment for those problems are the same as, essentially the start of the treatment is the same as for any cervical or neck problem. We start with physical therapy, anti-inflammatory, soft collar, injections, home cervical traction. Some people do alternative therapies. Obviously in this area, acupuncture is very popular. And people ask me, well, should I do acupuncture? And then I ask them, did it work? Okay, the rule is, if it feels good, it's good. If it feels bad, is bad. So if it didn't work, don't do it again. So, and then when we proceed to failure of non-operative treatment, meaning we've tried all these things and nothing is working, then we can talk about surgery, which is failure of non-operative treatment, progressive neurological deficit, where I see you back and every time I see you, your nerve is getting weaker and weaker and weaker. That's an indication for surgery. Because that's, you're in danger of irreversible nerve injury. I'm sorry that this red flags part didn't come out. Don't worry about it. It's basically, these are things that require immediate surgery, basically a fracture, dislocation, tumor, infection, rapid loss of motor function, pain uncontrollable with medications. So there's basically only 3 surgeries that we do. Well, I only do 2 surgeries in the neck. We go through the front, we go through the back, or we go through the back and the front. So this is going through the front. It's called an anterior cervical discectomy and fusion. For example, Peyton Manning had this kind of surgery. And we make an incision in the front of the neck. We go past the esophagus, past the trachea. Don't worry, we do it all the time. It's perfectly fine. It's actually much less painful than going through the back of the neck because we don't cut any muscle in the front of the spine. We slide around the muscles. And basically what we do is we remove the disc, we put in a little spacer between the bones now that we remove the disc, and we usually put a plate and screws on it. There's various different constructs that can do this. However, this is one of the most successful operations in all of spine surgery, between a 95 to 98% patient satisfaction rate. Then we can sometimes have to go through the back of the spine. There are a couple of different variations of this, but essentially what we're doing is we're going through the back of the spine, we're exposing the nerve and spinal cord from the back, opening it up, taking pressure off of it, and then sometimes we have to put screws in from the back. And this is also, we do this all the time, don't worry. This is pretty easy too. And then sometimes we have a really bad problem like this unfortunate person who had a nice big ovarian cancer eating up their spine. So we had to cut out that entire bone, peel it off the spinal cord, and then put in a piece of leg bone into here from a donor, drive it into the bones, put some screws above and below, then put some screws in the back. And don't worry, we do that all the time too. It's not that bad. So success rates, like I said, in appropriately selected cases, in the easiest cases, some of the highest success rates in all of surgery. Obviously, the earlier you take care of a nerve problem, the better the rate you have to recover. If you wait 2 years with a floppy arm, and then you come back to me and you say, hey, can you fix it? I'm going, I can make it maybe a little better, but I don't think you're going to be perfect. The other issue that people ask about is that if they hear about, oh, I had surgery, or someone had spine surgery, and then they had to go back for more spine surgery, or something failed. And what happens is that if you have surgery in one area here, once you have that surgery, once it heals, usually within 2 to 3 months, it will never go bad again. It will be perfect. It will be healed. It will be solid as a rock. However, this part which didn't get operated on and that part which didn't get operated on can still go bad. So just because you need additional spine surgery doesn't mean that the original surgery went bad. It's not like a gallbladder where if you have to go back for a gallbladder after your gallbladder was removed, that's bad. This is a little different. But if you have disease in one part of your spine, you probably have disease in all of your spine. Now, what we do is we try to minimize the amount of surgery that you need. Obviously, we don't want to be operating on stuff that doesn't really require surgery this time. But the caveat is that, you know, with the average life expectancy of a male pushing 80 years old, you know, you operate on someone, most likely, if they already have disease in their spine, some other part of the spine is going to go bad. So the statistics are, if your the problem in your spine is bad enough to need surgery, there's a 20% chance after you have these kinds of surgeries that another part of your spine will wear out and require additional treatment. That doesn't necessarily mean, but can often mean additional surgery within 10 years. That means an 80% chance you don't have to see me again. But we're trying to improve those things, so the future is something called cervical disc replacement. This is a picture again of the fusion that we did. However, what we are doing now is disc replacement, which is just like hip replacement, knee replacement. And this allows the shock absorbing motion to be maintained. And we believe that this will lead to more motion, quicker recovery, and fewer reoperations in the future because there's less stiffness in the spine. And the research so far bears that out. However, the FDA has only cleared that for patients under the age of 60 due to you need to have really solid bone for this thing to bite into. So if the bone is too soft, it just cuts through the bone, and it's not appropriate for softer bone. So moving on to the sleep portion of this. So remember, when it comes to the spine, the feels good is good. Feels bad is bad. I went to school for 11 years, and that's what I learned. Starting points for a good night's sleep. Head to toe. Starting at the neck. I get asked all the time about basically, you know, once you have spine problems, it really, really interferes with your sleep. So this is why, even though I'm not a sleep study expert, this is why I've researched and put into this talk all these issues about the sleep. But essentially, most of you have the wrong pillow. If you are a stomach sleeper, you need a thin pillow. If you're a back sleeper, you need a medium pillow. And if you're a side sleeper, you need the thickest pillow. So figure out how you usually sleep, and then you got to match the thickness or firmness of your pillow to your sleep. And then special sleep pillows. Many people have seen these Tempur-Pedic and all these other things. Many believe they help. However, no conclusive medical studies have proven improvement. That doesn't mean that it doesn't work. Let's go back to, if it feels good, it's good. But if it makes you feel worse, it's not your fault, okay? You can blame them, but it's not your fault. It's just that that pillow didn't match you. And then moving on to the mattress. What is the best mattress? I get asked this 5 times a day. The best mattress, and I will tell you the same time, every time, the best mattress is the one you like the most, that makes you feel best. Every human is different. One person's heaven bed is another's torment. Now, more expensive mattresses are more expensive for a reason, because they generally have more coils, which distribute the weight more evenly. However, firmness is very arbitrary. There's a very small increase in satisfaction with medium firmness mattress as opposed to firm and soft. However, that doesn't mean that, just because that's true across large populations, can be a starting point for you, but that doesn't mean that it is something that necessarily will match you up. There is no orthopedically approved mattress pillow that has been approved by any major orthopedic surgical society. Most of the ones that you'll see that are advertised are approved by the society that was started by the founder of the company. And then if you want to sleep on the floor, that's okay. People have been doing it for 300,000 years. But feels good is good, feels bad is bad. So don't listen to your friends. Don't listen to your brother-in-law. Don't listen to anyone else. Listen to your spine. Your spine is the expert. Your spine will tell you what feels best. And then for my spine patients and also people who have trouble finding sleep, sleeping on one side with hips and legs bent with a pillow between the knees puts the least amount of strain on the spine. However, if you have trouble sleeping because of lung issues, heart issues, and stuff like that, that does take priority. We know that cooler rooms encourage lower body temperature and hastens the onset of sleep. So don't go to sleep in a sauna. Alcohol, caffeine, tobacco, obviously not good for sleep, especially right before. Moderate exercise, 1 hour before sleep, is correlated with the best sleep. That is not vigorous exercise. And how they define moderate is kind of more light exercise to me, but you want to take a 10, 15-minute walk or just go up down the stairs a few times just to get the circulation going, I think that would be perfectly fine. If you're going to do that 5 minutes before sleep, that's not a good idea. But 30 minutes or so ahead of time, just getting the blood circulation going, just getting the oxygen pumped through your body, I think that's an excellent idea. And that's it.